this week on the BackTable Podcast.
This is, I would say, the most comprehensive book out there on thyroid and parathyroid surgery, written by some of the most famous endocrine surgeons, endocrinologists in the world from all over the world. I wrote this book as a dedication to my daughter, who was killed in an accident about 4 years ago. I guess that was the impetus for this book. It's unique amongst textbooks because it is the first book written for the modern learner, if you will. I say that because people of other generations learn differently than perhaps we did. So I'm very proud of this, and hopefully people will learn a little bit about thyroidology and parathyroid surgery and disease.
Hey everybody, welcome to the BackTable ENT Podcast. Our mission here is to bring you high-quality otolaryngology content that enhances your medical education and gives you answers to those burning questions that pop up in your day-to-day work. We accomplish this through thought-provoking conversations with experts in the field, and we hope that you can take this information and apply it to your practice. Quick introductions. My name is Ashley Agan, and I'm a general ENT practicing in Dallas, Texas.
And my name is Gopi Shah. I'm a pediatric ENT in Dallas, Texas at UT Southwestern. So excited to be here today. Ash, how are you doing this morning?
I'm here, Gopi. I'm a little bit nasally, little allergy ragweed going on down here in Texas. But excited to be here, excited for our guest today.
Yes. So let's get to it. We have Dr. David Goldenberg. He's a professor and chair of the Department of Otolaryngology at Pennsylvania State University in Hershey, Pennsylvania. He's a head and neck surgical oncologist. He was educated at the Ben Gurion University in Israel. After completing his residency in otolaryngology head and neck surgery at Rambam Medical Center in Haifa, Israel, he went on to do a 3-year fellowship in head and neck surgery and oncology at Johns Hopkins Hospital in Baltimore. Dr. Goldenberg just published a comprehensive textbook, Head and Neck Endocrine Surgery, and he's here today to talk to us about evaluation and management of thyroid nodules in adults. Welcome to the show, Dr. Goldenberg.
Thank you so much, Gopi.
So, Dr. Goldenberg, can you just first tell us a little bit about yourself and your practice?
Sure. So I'm a head and neck oncologist, and I've been at Penn State for maybe 16 years. I guess my practice has evolved into primarily endocrine, so thyroid and a lot of parathyroid disease. And yeah, we have a very robust practice. We're the only academic institution in central Pennsylvania. So all comers from New York down to West Virginia come to us. We see all manners of pathology. And I'm excited to talk to your listeners about thyroid nodules because there's been an evolution.
Yeah, I think that's, one of the things I'm most looking forward to hearing from you about, because I think, when we think about thyroid nodules, historically we were maybe over treating them, right? And then now maybe there's some newer ways to make more conservative, there's ways to, do some more active surveillance or other things where maybe we aren't taking out as many, maybe not every thyroid nodule needs to come out. Can we get into kind of how these patients present to you and what that looks like?
Ashley, that's a really good point. And when I mentioned that I've been here for 16 years, I can tell you that the way we looked at and treated thyroid nodules and thyroid cancer back then was very different than we do now. And you're right, we are more conservative. We're doing less, what I guess we can call now in retrospect, unnecessary surgery, which is certainly good for the patient. The vast majority of patients present with an incidentally found thyroid nodule. They fell off a ladder, they had an accident, their place of business sent them for a free screening Doppler of the carotid system. Vast majority. Every now and again, you have a patient who comes in because their gynecologist did a really thorough exam and found a nodule, but the overwhelming majority of these are incidentally found, which is kind of important because that scares patients. It really scares them to know that there is something. Now, thyroid nodule is very common. I wouldn't even call it a pathology, but that's not the way a lot of patients see it. So yeah, that's the way the vast majority come. I'd say 90-95% of patients come in with an incidentally found thyroid nodule.
Of the patients that you see, Dr. Goldenberg and Ash, how often can y'all palpate them? Like, is this something you're like, oh yeah, there, I feel this, or it's truly the screen. And when you examine the neck, you don't really feel much. Is that common?
Typically, if the nodule is about a centimeter or larger, you can palpate it. Sometimes patients are now sent to us because of, the high resolution imaging techniques that we have. Sometimes patients are sent in with a very small nodule, and admittedly, I can't palpate it. But to the patient, it's still there. Oftentimes, they don't really care what the size is.
Yeah, that's what I see a lot too. And sometimes I'll just be like, I don't feel it, but it's there. It's this big. So then what's next? What imaging do you like? Do patients already come in? I mean, let's say they came in with the cervical MRI, looking at their neck pain, and it happened to pick up maybe a nodule. Is that good enough, or what's your imaging modality of choice?
Well, the imaging modality of choice for anything thyroid, whether it's in the thyroid or in the neck, is the ultrasound, the good old-fashioned, inexpensive, non-radiating ultrasound. And it's an interesting point. If they come in with their MRI, that's wonderful. I don't really like it when they were sent specifically for an MRI for a, 5 millimeter nodule. But it happens sometimes. Again, when patients are referred into our practice specifically for this, oftentimes they come in with all kinds of imaging. But ultrasound is the tried, true, tested imaging modality.
Do you do any ultrasound in your clinic, or are most of your ultrasounds done in your radiology department?
I'm fully credentialed to do ultrasounds, and I'll do them every now and again myself if I think it will add something. A lot of times the patients are sent to radiology just because of timing. Just takes a while. And sometimes patients will come in with an ultrasound already performed. So it's a whole bag of, but certainly in our offices, we'll do an ultrasound if we think that it will add something. Yeah. Labs, typically TSH, if it hasn't been done, is the only thing you really need. And that's just to rule out a toxic nodular goiter. Incredibly rare in this day and age.
I assume that usually if there's a concern for a thyroid nodule and you send them for an ultrasound thyroid, you also have them scan the neck, both sides, one side.
Gopi, that's a really interesting point. I teach my residents that a thyroid ultrasound must include both sides of the neck, because regardless of the nodule size, regardless of how benign it looks, if the patient has abnormal looking lymphadenopathy, that trumps everything. Ultrasound is excellent for looking for abnormal lymph nodes in the lateral neck. It is not sensitive for looking for lymph nodes in the central compartment while the thyroid gland is in situ. So, if they see something, that's also suspicious, but if they don't see something, it doesn't mean that it's not there. Ultrasounds are so good nowadays that we can get an inkling of the suspicion for malignancy in a thyroid nodule based on findings on ultrasound. So if someone comes in with a cystic lesion, purely cystic, the chances of this being malignant are very, very low. On the other hand, if a patient comes in with a nodule which has, microcalcifications, hypoechoic irregular margins, taller rather than wide, mixed cystic solid component, all these things say to me that the chances that this nodule, regardless of size, may be malignant, and we'll probably take that to the next diagnostic level.
In terms of just purely cystic, is there ever a size criteria where you still need to consider taking it to the next level?
If it's purely cystic, it doesn't mean that I won't do a fine needle aspiration biopsy. Oftentimes you just get gooey thyroid juice with no cells, for a lack of a better term.
It's right on. The description was good. I could see it.
That's what it typically is. And if it's really, really large and cystic, I remember an elderly lady who came to me who had a 13 centimeter cyst, and it was causing compressive symptoms. And eventually she went to surgery to get rid of it. In that case, I aspirated under ultrasound in clinic and just, took out 20, 40 cc's of this goo.
Wow.
Just to give her some relief, telling her this is absolutely going to come back, but this will make you feel a little bit better. But cystic lesions, purely cystic lesions, are rarely anything to be concerned about when it comes to malignancy. However, sometimes they can be bothersome.
So moving on to FNA, what's your criteria for FNA? Does every nodule get an FNA? Is there a size where maybe it's too small to get? And then how does the workup proceed from there?
So no, not everything gets an FNA, and not every nodule is FNA-able. And often we have a conversation with the radiologist, if they're doing the FNA, as to whether this just is justified or not. And I absolutely encourage a very good working relationship between the otolaryngologist, the pathologist, and the radiologist. And we have that here. Open dialogue, is it, why not, etc. So certainly anything larger than a centimeter that has suspicious features will get a fine needle aspiration biopsy. The issue of below centimeters, which is a microcarcinoma, and remember, a centimeter is relatively arbitrary. 0.9 is not a centimeter. Is it a microcarcinoma? If there are highly suspicious features, I will have this undergo fine needle aspiration biopsy. And I know that there is some discrepancy amongst those who say, well, if it's very small, it's not going to do anything anyway. That being said, I'm old enough to have seen many a microcarcinoma send cervical metastases. So I also, in my neck of the woods, and this is just where I practice, patients are not willing to hear, yes, it may be a cancer, but let's just watch it. They're just not. So typically a centimeter, I guess we have to ask ourselves, what about the opposite side? Are you going to get a biopsy if it's larger than 4 centimeters? Because there are those who say that larger than 4 centimeters, the fine needle aspiration biopsy is, and I quote, wildly inaccurate. And I don't agree with that. First of all, your fine needle aspiration biopsies are typically as good as the person doing them. They're operator dependent. In my institution, they're excellent doing this, and they can get a nice diagnosis. You throw in molecular testing, it already becomes more accurate. So I do not believe that the size of a nodule in and of itself is a criteria for surgery unless it's bothering the patient. So if you say to me, I feel fullness when I lie down, or I have a swallowing difficulty that I believe is attributable to this thyroid nodule, then maybe. But if the patient doesn't know about it and it's 4.5 centimeters, I'm still going to send it for a fine needle aspiration biopsy.
And you just made the point of it's operator dependent. So that is why a radiologist, IR, whoever that does a lot of these is doing these FNAs. Is this something that ENTs are doing in their clinics?
Absolutely.
Okay.
And when I had more time, I was doing these in my clinic, and we'd have do smears. And in my institution, it just flows better for them to do it. They do it pathology and radiology together. And what they have that I don't have is they can take the aspirate and look for adequacy of cells. And I can't do that myself. So in my institution, we found it to be in the patient's best interest to do it that way. Certainly, if it's urgent, I have no problem putting a probe on, making smears in clinic, et cetera, et cetera.
And then talking about cytology or FNA, what are we looking for?
Typically, what the cytopathologist is looking for is papillary thyroid cancer. Now, why do I say that? First of all, the overwhelming majority of these are going to be papillary thyroid cancer if they're going to be a cancer. Okay? The second most common, follicular thyroid cancer, as well as its cousin, Hürthle cell cancer, you cannot make the diagnosis by fine needle aspiration biopsy because the criteria that differentiates malignant from benign are invasion of the thyroid capsule, the capsule of the tumor, and invasion of vasculature. And neither of those things can be seen on FNA. Medullary thyroid cancer, very rare. I recently had a lady who, she had a biopsy which was indeterminate, and it turned out to be medullary thyroid cancer. So that certainly can happen. And, usually, obviously, the more horrific thyroid cancers, such as anaplastic and lymphoma, are not subtle in their presentation. But, if we're looking for papillary thyroid cancer, they look for nuclear inclusions and nuclear grooves and nuclear enlargement, that kind of thing.
And then, when you get your FNA report back, you're going to see the more straightforward results are usually going to be your benign or malignant, right? We know that if it's malignant, we start talking about treatment. If it's benign, then, and the characteristics fit, then we say, okay, maybe we don't need it. I think it's the indeterminate, the atypia of undetermined significance, things that are in the middle that can be more nuanced in the further management. Can we talk about that a little bit?
That's a really good point, because that's a concept that is a little bit more complex to explain to patients. Patients want to know, is it good? Is it bad? Is it cancer? Is it not cancer? So what happens is really interesting. Patients are often referred by an outside physician with a diagnosis of cancer that they don't have. So I get to tell them, hold on, it's not, the chance of this being cancer is 30%. Let's talk about it. Sometimes patients will be sent in and they understand it as, well, it's not cancer, but it's not right anyway. So I have to go, and this is really important to explain to patients. And what I typically say is there's about 6 categories that this could be. 2 of them are very straightforward. If it's cancer, we'll talk about treatment and you'll be fine. If it's benign, then depending on what it is, you'll either go home and we say goodbye to you, or you'll be watched every year, every 2 years, or referred to endo or something like that. And then we talk about other things. So non-diagnostic, what I tell the patient is sometimes the nodule doesn't give up cells. Okay. And again, it could be operator dependent, but sometimes it's actually the nodule that doesn't give up cells. It happens. And our choice is to either watch it or to repeat it, depending on the patient, the specific points of this patient, or their ability or inability to sleep at night. Then you come in with the atypia and follicular neoplasm, or suspicious for follicular neoplasm. And for the last, it's got to be almost a decade, maybe a little less, we've been sending these out for molecular testing. We use ThyroSeq, and another one is Afirma. Those are the 2 big boys in town. And what this does is it helps us rule in or out cancer more accurately than cytopathology alone. And I explain that to the patients. Bethesda 5 is called suspicious for malignancy, and theoretically, you can send that out for molecular testing too. In my experience, I have never seen a case that was suspicious for malignancy that was not, in fact, malignant. And I treat it as such, and I explain this to the patients. We see a lot of thyroids, a lot of thyroid nodules, and we send out a lot of these for molecular testing. And in the vast majority of cases, it saves the patient an unnecessary surgery. So before molecular testing, if someone came in with a Hürthle cell neoplasm, the implied risk of malignancy, right, is up to 30%. And I tell the patient, we recommend that you take out half the thyroid gland just to make sure. It's a grand biopsy. Nowadays, we're doing a lot less than those, a lot less than those. Another interesting thing that we've been learning, if someone has a BRAF mutation, we know that they have a thyroid cancer. But now we're learning about co-mutation. So if someone comes in and they have a BRAF mutation together with a TERT mutation, well, not only do they have thyroid cancer, but there's a good chance they have a very aggressive thyroid cancer. And you have to speak to them about that and let them know. So that's a conversation that has to be, like you said, I think, Ashley, it is nuanced, but it's, it's in the patient's best interest.
Yeah. And I think, another one that situations that I find that can be difficult are a larger size nodule. So, maybe 2 to 3 centimeters, and you get a benign FNA, and maybe there's some it's the radiology features for the ultrasound are not perfectly cystic. There's some suspicious features. And then having that conversation with the patient about, do we feel like we got a good enough biopsy to really say this is benign and not worry about it? Or I would be curious, which one worries you more, the FNA results or the radiology, ultrasound features?
So that's a great question, Ashley. So what do you do about discrepancies? What do you do when things don't line up? So in this day and age, this is a conversation that you have with the patient. And although they taught us in medical school to speak with patients, I don't think maybe they're teaching it now, but not all patients are created equal. Some of them have an understanding, some of them don't. Some of them don't want to have an understanding. You're the doctor. You decide. To which I usually answer, it's your neck. You decide. But it's a conversation and we do it together. So we have to ascertain the patient's risk aversion. We have to ascertain whether they can sleep at night, whether they're an upstanding citizen who's going to come back for another ultrasound or biopsy or disappear in the wind, only to come back 5 years later with an anaplastic thyroid cancer. These are things I've all seen. So all of these things, it's not just the FNA, it's not just that. Conversation has to be had. I think you'll never go wrong if you bring the patient back for an ultrasound in 6 months. Never. I also don't think that you're wrong if you do a lobectomy on a patient like that because they can't sleep at night thinking that there's a chance that maybe it's a cancer. Certainly years ago, we did a lot more lobectomies. We know how to do that. We know how to do it well. The patients will be great. It's not the wrong answer either. Last week, I had a patient who came in with a biopsy in an outside institution that was sent out for a FIRMA, 50% chance of malignancy suspicious. I always bring the path in to our institution. I have a patient who came in with a fine needle aspiration biopsy in an outside institution that was a FIRMA suspicious, 50% chance of malignancy, sent to me for a lobectomy. I always ask that pathology be brought to our institution because I always think a second opinion by people who are experienced is never a bad idea. Well, our people said there's insufficient cells to call it anything. So I sent her for another biopsy. My new biopsy came back completely benign. So what do? Do we believe the old one and give her a lobectomy, which is probably unnecessary? Or do we wait? So it's a discussion I had with the patient. I try not to push patients one way or another, but if they now, I'll say, listen, if I think you're doing the wrong thing, I'll say to you, I think you're doing the wrong thing. In this case, we're going to get her an ultrasound in 6 months. Even if this is a papillary, these are slow-growing cancers. We all know that. The main thing is not letting the patient get lost and having a follow-up system so that you keep an eye on them.
Does insurance cover the molecular testing for these patients, or is there a criteria that you have to show for them to approve it?
So this probably is different in every institution, but the way that we do it is that, and this was the agreement when we brought this molecular company on board in our institution, was if insurance does not cover it, the patient will never get a bill more than a couple of $100, which I think is reasonable. Our endocrine surgeon has a long conversation with them about it. I typically don't. I've never had a complaint about it. But, insurance is a funny thing. Well, I have nothing nice to say.
And then can we maybe just go back for a second?
Sure.
Does having more than one nodule make a difference in those questionable cases or at all in your workup?
That's a great question. So the old way of thinking was the more nodules you have, the less likely any one of them is to be cancerous. On the flip side, we've all seen multifocal papillary thyroid cancers. If someone comes in with a multi-nodular goiter that looks like a multi-nodular goiter, it typically is. If one or two of the nodules there are suspicious specifically, certainly you can have a thyroid cancer and a multi-nodular goiter. But usually the patients who come in, they have a solitary thyroid nodule, which is, I guess, more suspicious. But I certainly would not, poo-poo it just because they had a couple of nodules and say, wow, this one is really suspicious, but since you have another two, it can't be cancer. I would never do that.
And it's appropriate to biopsy anything suspicious, I would assume, right? If you're sending them for FNA and you have a couple suspicious nodules, go ahead and stick a needle in both of them.
Typically up to 3. That's what I typically do. If that 4. But usually the idea is if someone has a multinodular goiter, and we've all operated on these patients, it looks like a bag of grapes. They can have 20 of them, 30 of them. It's not reasonable to biopsy all of them. We typically biopsy the ones that may be suspicious, up to 3 typically.
And then in terms of workup for your nodules, for some of the cases that aren't as clear cut, the example that Ash gave was a great one. Do you ever use a PET scan, or is there a role for these other imaging modalities, and how do you use them?
That's a wonderful question because we see this. So the vast majority of people with PET scans are people who come in with a PET scan for another malignancy and they find a solitary FDG-avid nodule. And those are actually considered suspicious and need to be worked up, and they are. So the patients come in with a PET CT scan for another reason. If there's a solitary FDG avid nodule, it needs to be worked up. Usually they get a fine needle aspiration biopsy under ultrasonic guidance. In those cases, they don't need a neck CT because the neck is covered by the PET. And overwhelmingly, if the thyroid cancer is FDG avid and it's a cancer, it's usually more aggressive because it means it's probably not iodine avid, and the opposite. So I do remember a couple of patients who accidentally came in sometimes a patient will not be sent to us or to even endocrinology by a PCP because they hear the word cancer and they send it to oncology and they do a PET scan, probably unnecessarily, and you see it. So this is kind of anecdotal, if you will. So no, we don't send for a thyroid nodule for a PET scan. If I'm doing surgery on a patient that already has a thyroid cancer, or if a thyroid nodule, like if someone comes in with a thyroid nodule and they are complaining of compressive symptoms, my rule is that I have to be convinced that it is the thyroid nodule that is causing their compressive symptoms. The reason being, there's an old saying, you break it, you buy it. So once you've operated on the patient, they're yours for life. And if you're taking out half their thyroid gland for no good reason, you're not going to make them happier because thyroidectomy doesn't typically cure reflux. So I'll get a CAT scan on someone who is complaining of compressive symptoms, and I will go over the scan together with the patient and say to them, you know what, you're right. Your massive thyroid nodule is compressing your esophagus or pushing on your trachea. Let's take out the lobe. Or I'll say to them, your thyroid is really not that large. We have to look for another reason to explain your compressive symptoms. If it's a thyroid cancer, I reserve the right to do a CAT scan with contrast if I think it will help my surgical planning, usually if there's extensive neck disease. I say I reserve the right because in certain places, nuclear medicine gets up in arms over the use of contrast. I think it's unwarranted personally, so we do what's right for the patient if I think a CAT scan will help, but it's not a routine thing that I'll do for any old thyroid nodule.
And the concern is timing for post-op radioactive iodine. Is that right? They're worried that it's going to delay that treatment if they need it.
Yeah, that's the concern. I don't buy it. First of all, it takes a while to get the nuclear scan, the iodine treatment, at least in our neck of the woods. I'm sure the iodine from the CAT scan has washed out long ago. But in any case, my ability to perform surgery is at that point the more important thing. It's a surgically treated disease, right?
Yeah, absolutely. So I think that's a good pivot point to kind of move on and talk about the surgical decision-making once you've decided that surgery is warranted and indicated. And so what are the different scenarios where it may be appropriate to do, lobectomy versus total thyroidectomy, adding in central compartment neck dissections and, versus lateral neck dissections? Let's get into that part.
Great question. Like I said before, my decision-making has matured over the years. I'm much more conservative about leaving someone half a gland, even in the face of cancer, than I was. So, when I finished my fellowship and when I came out here, every patient who had a malignant thyroid neoplasm got a comprehensive neck for if they had neck disease as well as a total thyroid. That was it. And plus, minus, but more plus radioiodine. Certainly for an indeterminate nodule, I don't think it's justified to take the whole gland. For a malignant neoplasm, a papillary, it is justified to take the entire gland, except if it's a very small cancer, if it's a young woman, if it's an upstanding citizen who doesn't want it and they're going to come back and be watched, then I'm okay leaving half a gland and the patient gets to keep their thyroid function, but they can't get radioiodine if needed.
Right.
So regardless of what surgery a patient gets, if it's malignant, I tell them lifelong surveillance. Long after I'm in an old age home, I have seen people recur 35 years out. So for an indeterminate thyroid nodule, I'm not going to take out the entire gland. Sometimes, to keep things fun, there are, what do you do if you have two indeterminate nodules, one on each side? Happens. What do you do if you have no clear sign of malignancy on the onset, but it's malignant? So case in point, I had a lady who came to me, I operated on her maybe a week or two ago. She came to me with what they called on a scan, I didn't send for the scan, it was a CAT scan, a perithyroidal mass. So I had it needled and it came back as, I don't know what it is, nothing. No thyroid cells, no, just a very, nothing. Well, there's a mass next to the thyroid, kind of looks like a Met to me, but I don't know. So, we went in there and we pulled this thing out and sent it for frozen. And the pathologist said, well, and I look, I go over to the gross lab and there's obviously thyroid cells in this mass, this lymph node, but he can't call it cancer on frozen. Now, what are the other reasons that you would have thyroid cells in a lymph node? So then there's the old thing that we all learned in medical school. Well, maybe it's a rest of thyroid tissue outside the thyroid. What do we do? She had another rest of thyroid tissue, huge one in the mediastinum, and I took out half the thyroid. And I did a central compartment. I took out this node, which was sitting, and it's interesting, this node was, and I really don't blame the radiologist, it was more central compartment than lateral, but it was sitting in between the great vessels and the vagus. So it was kind of splaying the vessels. So it wasn't lateral to, wasn't really medial to, it was kind of in between two. So in this case, I took out half her gland. Took out all the nodes. I spoke with her mom who was waiting downstairs and I said, this is probably thyroid cancer. She probably will need a completion, but I'll come back and do it another day because I'm not going to rob this young lady of her entire gland with no clear diagnosis of thyroid cancer, even though it was screaming thyroid cancer to me. But, these are judgment calls. You really it's not always simple. Sorry if I digressed from your question.
No, it's so true. It's like most of them aren't the straightforward, simple ones. I feel like these are the conversations that I'm having all the time. Do you have a cutoff for your, the size wise, if you're deciding you want to do just a lobectomy only, or it just depends?
No, I'm very careful not to use size as a criteria for half a gland or a whole gland. I've seen too many where people take out the whole gland needlessly and something goes awry. I will say this, obviously the most common cause of litigation over thyroid surgery is damage to the recurrent nerve, right? We all know that. But amongst that, most of the cases and most of the successful cases, patients or doctors who go over to the opposite side and trash both nerves when in retrospect it should not have been done. And that's very, very hard to defend. So you got to do the right operation for the right reason, knowing full well that even if it's thyroid cancer, but certainly a benign disease, you can always go back and fight another day. Use the same incision and you take out the other side when needed.
That's a great segue into your peri-op, intra-op, post-op. What do you do for the nerve? Are you scoping everybody before surgery, after surgery? Do you use a NIMS? Do you not use a NIMS?
Yes and yes. I scope patients all the time. That's one of the things that we as otolaryngologists can do, and we do it, and that's the way to evaluate the vocal cords. So yes. And we use neural monitoring every case, every time, for every thyroid, every parathyroid, and every parotid. We have a neural monitoring service. We have our dude or a dudette sitting in the corner, and they have oversight of a neurologist, and they monitor the recurrent laryngeal nerve. I would be remiss in not mentioning the fact that this is an adjunct and that the gold standard for thyroid surgery is anatomically finding and preserving the recurrent laryngeal nerve. And it's really fascinating. If you look at the literature, the higher the volume a thyroid surgeon is, the more likely they are to use intraoperative neural monitoring, which is counterintuitive. It's a good teaching tool. It's also very important not to let your trainees become dependent on it. So I don't let them do anything until they've found and shown me the nerve, traced it up and traced it down a little bit so that we're sure it's the nerve. And so I use intraoperative neural monitoring. We find the parathyroids every time. I guess standard, hopefully good practice, thyroid, capsular dissection and thyroidectomy.
And then when patients come out of surgery, do you scope them post-op, in the immediate post-op period, or wait till you see them in clinic, or just if you're worried about them, kind of following them clinically?
If I'm worried about them, then obviously I'll scope them, but thankfully typically it's in clinic a week or so later.
What's your protocol for managing calcium for totals?
Well, typically we measure their calcium in the AM, and if it's stable or improving, they go home. I personally am, like I said, a little bit more conservative, so all my thyroids stay overnight, 23-hour stay. The reason being that, as I stated in the very beginning, we have a large catchment area. And first of all, I try very hard to treat all the patients the same. And if someone lives 4, 5, 6 hours away, I don't want to send them home right after surgery, and I don't want them finding their way to a small emergency room in the middle of the night when something goes awry, either for real or not. And the vast majority of patients are okay with that. They stay 23 hours. And we do is we measure their calcium, and patients are sent home in my practice with, if their calcium's above 8, they go home with calcium carbonate 500 TID. And if they start, dropping and so on and so forth, we'll add on calcitriol, obviously not including postpartum, which are treated a little bit differently. And if we have any inkling that something is not right, I have a very low threshold for consulting our endocrinology colleagues. This typically occurs when you're doing bilateral central compartment lymph node dissections, because if the disease is bulky, sometimes you must sacrifice 2 lower parathyroids. So I really try very hard to preserve the upper ones. I like to preserve them in situ, although I will take it out and chop it up if it's impossible. That's about it, I guess.
Question just popped in my brain. What about drains? Do you routinely leave drains in your patients, or never, or sometimes?
I don't leave routinely. I don't use drains routinely. I haven't for many, many years. The only time I'll put a drain in is if I am doing an extensive dissection, a massive goiter, anything that's going to leave dead space. If I'm doing 2 necks and bilateral central compartment and a thyroid, person's going to get at least 1 drain, 2 drains, but they're also going to stay a couple of days. So,
yeah, that makes sense.
But no, I don't routinely use it for every thyroid. And by the way, the patients really hate drains. I don't know why.
Know.
I've never had one. They hate drains. So they're usually very happy when you say no drainage tube.
Yeah.
Children don't like drains either. Just that's my addition to this. Anyways, Dr. Goldberg, thank you so much. I feel like we're kind of wrapping up. Is there any other final pearls for our listeners for thyroid nodules in adults?
No, I think we've really covered it. Surgical judgment is I call it the cousin of common sense. You really have to know the literature. Things change all the time, and have a frank discussion with your patient. I feel if you explain it to the patient, you're explaining it out loud so that everyone's clear as to what the goals are, why you're doing something. Do you want to ask me about my book?
Yes, I was about to say before we let you go, we need to plug your book. Tell us about your new book, and so where our listeners can check it out.
Thank you. Yeah, I just published a comprehensive textbook and surgical and video atlas on head and neck endocrine surgery. It's published by TEMA. Probably can get it at TEMA or at Amazon or wherever they sell books. This is, I guess, my 7th or 8th textbook, and it's certainly the most important work I've done to date. This is, I would say, the most comprehensive book out there on thyroid and parathyroid surgery, written by some of the most famous endocrine surgeons, endocrinologists in the world from all over the world. I wrote this book as a dedication to my daughter, who was killed in an accident about 4 years ago. I guess that was the impetus for this book. It's unique amongst textbooks because it is the first book written for the modern learner, if you will. I say that because people of other generations learn differently than perhaps we did. And what we, or when I say we, I mean me. When I did. You guys are obviously far younger than me.
But I get it.
What we did is every chapter of this book has bulleted points to open. Every chapter has a case report, okay, to help illustrate what it looks like in real life. Every chapter has what we call points to ponder. These are a little blurb in between sections that force the reader to answer in their own mind a clinical question regarding the thing that they just read. And finally, every chapter has between 3 and 5 of the seminal landmark references in an annotated version, meaning each one of them has a small abstract. So I'm very proud of this. And, hopefully people will learn a little bit about thyroidology and parathyroid surgery and disease.
That's wonderful. Congratulations. That sounds like
Thank you.
quite a
Thank you.
work. I'm excited to check it out.
And you said this was the 6th or 7th textbook, correct, Dr. Goldenberg?
7th or 8th, I think.
Wow.
I'm trying to look. I don't know. We're,
Congratulations. That's
Thank
a
you.
whole other podcast in itself on how to write a textbook.
Sure.
You want to tell us a little bit about the ENT program at Penn State? How many residents do you guys have?
So we have 2 a year, hopefully to be augmented. And we have something actually very unique is we have a resident research program whereby one resident of the 2 we take a year goes into the lab prior to their intern year, not after their intern year. And we are doing in our lab thyroid cancer and head and neck cancer genomics, amongst other things. It's an interesting group. Obviously, like any other otolaryngology program, we get the best of the best. It's very competitive, but, we get great people, a very cohesive group. From the department standpoint, like I said, we're the only academic show in town, so we get anything that's weird and wonderful, tons of trauma, tons of head and neck oncology. Yeah, I say a case report walks in the door every day. Yeah, so proud of the program. Very nice. We're in a beautiful rural setting in central Pennsylvania, but it's a growing health system. So proud to work here. Great people.
Awesome. I guess that's a good place to put a pin in it. Thank you so much for your time today, Dr. Goldenberg. It was a really great talk. We appreciate it. I think that our listeners will really get a lot out of it.
Well, thank you very much, guys, for having me do this. I truly appreciate it.
You can find us on SoundCloud, Spotify, iTunes, Apple, and Ghana. Please follow us on Instagram and Twitter @_BackTable ENT. We love feedback. Reach out to us for topics, ideas, speakers, or if you ever want to come on a show.
And don't forget to subscribe, rate, and share. That's a wrap. Thanks, everybody.